The talk today is comparing empirical ways to improve student health. My name is Cheney. I'm faculty in the UCR School of Medicine. I'm also the academic lead for Voicing Collegiate Recovery, which is the project that we will talk to you about this evening. Thank you all for coming here. Tonight's talk will include 3 different presenters. Sarah Pemberton, who is here in the audience, Lisa Molina, and myself. So the goals of tonight's talk is to discuss our current campus and off-campus treatment of students with substance use concerns. We will also understand the meaning of evidence-based intervention. So a lot of times that word is used, and tonight we'll talk about what does it actually mean. And then discuss how students, the campus community, our campus and community partners can use this approach in research. And if you were not at our first talk, I just want to make sure that everyone's aware that this is part of our Voicing Collegiate Recovery project, and this is our partnership team. So we have UCR faculty members, staff, students. We have chairs and members, our chair of the UCR Collegiate Recovery Advisory Board, Francis Fernandez. Solid Ground Wellness and Recovery, Lisa Molina, who will be speaking tonight. Representatives from Healthy Campus, as well as from Counseling and Psychological Services, Sarah Pemberton, who will be speaking tonight, and then also our Student Recovery Group. This is part of an engagement award funded by CORI, which is Patient-Centered Outcomes Research Institute. Okay, and I am going to hand it over to Sarah Pemberton. You can clap. Oh. Is this or that?
Yes, I need the clapping. Thank you. Good evening. So yes, I'm Sarah Pemberton. I'm one of the licensed clinicians in the counseling center here at UCR. It's Counseling and Psychological Services, and you'll hear me say CAPS. That's like the abbreviation for Counseling and Psychological Services. I didn't actually start in CAPS. I started as the first social worker on campus. Back in 2008, I was the first student affairs case manager for UCR, which was very exciting to bring in that new position. Now there's like 4 case managers, and there's a whole department, and it's grown across UCR, but also across all UCs and across the nation. So it's an awesome position where I started working with distressed students, figure out how to connect those students with resources on campus and off campus.
As well as from Counseling and Psychological Services, Sarah Pemberton, who will be speaking tonight, and then also our Student Recovery Group. This is part of an engagement award funded by CORI, which is Patient-Centered Outcomes Research Institute. Okay, and I am going to hand it over to Sarah Pemberton. You can clap. Oh. Is this or that?
Yes, I need the clapping. Thank you. Good evening. So yes, I'm Sarah Pemberton. I'm one of the licensed clinicians in the counseling center here at UCR. It's Counseling and Psychological Services, and you'll hear me say CAPS. That's like the abbreviation for Counseling and Psychological Services. I didn't actually start in CAPS. I started as the first social worker on campus. Back in 2008, I was the first student affairs case manager for UCR, which was very exciting to bring in that new position. Now there's like 4 case managers, and there's a whole department, and it's grown across UCR, but also across all UCs and across the nation. So it's an awesome position where I started working with distressed students, figure out how to connect those students with resources on campus and off campus. And then in 2013, I moved over to CAPS, continuing to work with students, continuing to connect students and resources. Currently I'm doing individual therapy, a lot of case management, a lot of referral for resources on and off campus. And then I also provide the mandated substance abuse assessments on campus. So for students that have gotten connected with student conduct for some reason because of some substance use or a conduct violation regarding that, or they are through the Department of Athletics, they do regular urine testing through athletics, And if it has come up or a student in athletics has come forward and said that they have a substance abuse concern, those students are mandated for an assessment with me at the counseling center for that. And I've been doing that for 5 or 6 years. So that's part of my role here, is to function not only as a clinician in CAPS, but also to provide these assessments. And then also to be the hub for referrals for students who may be struggling, who are maybe looking for detox, they might be looking for IOP, they might be looking for different resources in the community. And I'm sort of one of those places in CAPS where the other clinicians can come to and say, here, this is the client that I'm working with, the student, what their needs are, and I can try and help them figure out what would be the best fit for them, for sure. So that's part of my role here, is to function not only as a clinician in CAPS, but also to provide these assessments. And then also to be the hub for referrals for students who may be struggling, who are maybe looking for detox, they might be looking for IOP, they might be looking for different resources in the community. And I'm sort of one of those places in CAPS where the other clinicians can come to and say, here, this is the client that I'm working with, the student, what their needs are, and I can try and help them figure out what would be the best fit for them, for sure. So just a little bit about CAPS. They're on-campus services for registered students. We have licensed psychologists, licensed marriage and family therapists, and licensed social workers. We do have a brief therapy intervention model there. Part of that is going to limit us in some ways of how we can help with long-term treatment for students that are struggling with substance use issues. But we definitely can provide that assessment for them, like I talked about with the voluntary or mandatory assessment. We take a lot of time with our students to discuss with them how their substance use may or may not be affecting the identified problem that they've come with, how it may not be affecting their functioning as a student, but also just as a person. Oftentimes this involves working with students in multiple stages of change. So many of you might have heard stages of change. For someone who's maybe looking to address a substance abuse issue, we work with really students that are in the pre-contemplation stage, contemplation, and even preparation stage, in the sense that you may see over even just a couple of meetings with them, they had no idea or no recognition that maybe substance use was affecting what was going on in the classroom or with relationships. And then the more we work with them, the more we talk with them, they're starting to realize, hey, yeah, maybe I do need to make some changes. Maybe there is something that it needs to happen here. And then we get to see them literally preparing to maybe exit the CAPS program and go into a supportive, like an IOP, an intensive outpatient program. They may be looking for a dual diagnosis program. They may be looking for just more intensive outpatient. They may be looking, oftentimes this involves working with students in multiple stages of change. So many of you might have heard stages of change. For someone who's maybe looking to address a substance abuse issue, we work with really students that are in the pre-contemplation stage, contemplation, and even preparation stage, in the sense that you may see over even just a couple of meetings with them, they had no idea or no recognition that maybe substance use was affecting what was going on in the classroom or with relationships. And then the more we work with them, the more we talk with them, they're starting to realize, hey, yeah, maybe I do need to make some changes. Maybe there is something that it needs to happen here. And then we get to see them literally preparing to maybe exit the CAPS program and go into a supportive, like an IOP, an intensive outpatient program. They may be looking for a dual diagnosis program. They may be looking for just more intensive outpatient. They may be looking AA meetings within the community. It could be all sorts of things. And so we're really trying to help them find the best resource that fits their need, because it's not, it's not cookie cutter. It's not one shoe fits all. Every student is unique. Their needs are unique. Their family is unique. Their insurance is unique. And so we need to really help figure out what's going to work best for them. We don't want to put a challenge in front of them, making assumptions of what they can and cannot do. Transportation can be an issue, so we want to find a provider that can help them with that. So there's all these different things that we have to look at to help a student be successful. And then we get them into whatever that action phase is, whatever that off-campus program is, and it could be in conjunction with services we're providing. It is really honestly unique to every student that we work with. And then oftentimes working with students who are want to come back. They feel like they're, they've successfully completed a program and they're sort of in a maintenance phase. Like now they want to work on what's it like to come back, maybe university without having the supports if they've had some time away, or maybe they're dropping their level of care and they want a little bit more support while they're here, or they just want to meet with someone that knows more of the resources on campus for them. We really enjoy working with those students as well. And I have to give a plug to Student Affairs Case Management because that's my origin. They help us quite a lot with these types of things too, working with referrals. It's a team effort to kind of make sure that we're meeting our students' needs. So that's kind of in a nutshell what we do at CAPS, and for our students that are looking to make change or simply just starting to consider it. I think next up we have Lisa Molina.
Good evening, everybody. My name is Lisa Molina. I'm with Solid Ground Wellness and Recovery, and we are a community partner that is working with UCR School of Medicine and the PCORI grant, and we're super excited to be a part of this. Personally, October of 1990, I survived a suicide attempt. I was pregnant, and I was strung out on heroin, and I tried to end my life because I just thought everybody would be better off, including my family and this baby that was in part of me. So at that point, the next day, I actually went into treatment. So that was 29 years ago this month. And I was fortunate enough to be able to work in the field of recovery. So for the last 29 years, I have been involved at some degree, either working with another treatment center, or in the last 3 years, my family, it's a family-owned business, we created Solid Ground. We do specialize in emotional wellness. It is not just about abstinence, it's about wellness, because we know that you can take away the drug and still be miserable. You can take away the drug and still have all of the isms that go along with addiction, problem use. And so we want to make sure that we attack all of the areas that would be, that a need would need to be met. We do have a strong one-on-one approach, so we do some group, but it's going to be very, very small. It's going to be 2 to 3, 4 maybe people in a group, so that it's a much more intimate setting. But we primarily will do individualized treatment. So we do work with a variety of treatment methods. One of those are cognitive behavioral therapy, or CBT. And cognitive behavioral therapy, it challenges faulty thinking. So you have a thinking pattern that's negative or it's faulty. It's telling you something is true that's not true. And so we identify what the emotional responses are, what the behavior is, or what we want to replace it with. And then we work with the individual to be able to create that environment. Motivational interviewing, it's a little bit different, and basically we translate into respect and acceptance of the individual of where they're at. It's not telling you, you need to stop doing drugs, you need to be better at school, you need to be more on time. Those are directions, and that is not motivational interviewing. Motivational interviewing looks more like, what is your typical struggle in your daily routine? What attributes to that? How does that? They're open-ended questions. It's not a yes and no question or an answer. It's really to get to a deeper thought, a deeper cognitive connection, and to determine for the client or the participant, they will be able to come up to their own aha. Oh, it's not because I'm scattered. It's because I'm using drugs until 3 o'clock in the morning and I have to be up at 6 for a class. And so we try to be able to do the reality testing with it and give the information. Motivational interviewing is very non-judgmental. So it's not about, oh no, you can't keep smoking marijuana. I mean, we ultimately want that to be the case, yes. However, it's not a prerequisite. It's what is your goal and why are you in treatment? What is it that you're struggling with, and how can we help, and what interventions can we implement that will allow you to move away from this place of addiction? And the decision to change comes from the individual, not from the counselor. It's not my agenda. It's the client or the participant's information. I think this is phenomenal. It's absolutely beautiful that we can bring the recovery services on campus, that we can be able to bring all of these different platforms together that typically don't work together and make it function and be best for the recovering individuals and people that are seeking recovery that are on campus. One of the other things that I let everybody know that, we've now have a contract, so we're able to go into the community to provide services. So if you as an individual have a certain Medi-Cal services or those types of things, we can actually come on campus and provide services to you right here where you're at. We can do that at a coffee shop, we can do that at a park. It's not traditional where you actually have to leave your setting, come into our environment for an hour or two, and then go back into your setting. So we are actually able to do that. And one of the other wonderful things is that we're able to do telephone and telehealth services as well. So you do not have to be physically in my office for us to be able to provide services to you. We're able to connect in the community at our office or over the telephone, which is pretty unique, and it's one of the first times that this has been offered in this county. Having said these things about the solid ground, and I'd like to know, would it be possible to use comparative effectiveness research in an effort to see if outcomes are impacted depending on where the delivery of services takes place? Thank you.
Okay, so let's all keep this question in mind. So the idea is it possible to use comparative effectiveness research to see if outcomes are impacted depending on where the delivery of service takes place? So very focused on the delivery. The delivery of an intervention, maybe that intervention is, as Lisa pointed to previously, motivational interviewing, or perhaps it's something like cognitive behavioral therapy. I am Ann Cheney. I am faculty in the UCR School of Medicine. Greer Sullivan is at Borrego Health. She is part of the research department at Borrego Health. Unfortunately, she's not able to be here with us tonight, so I am presenting on her behalf. This is not my expertise, so I'm going to try as hard as I can to relay this information well. I am likely going to call on Dr. Tanya Neary, who has experience doing comparative effectiveness research. Lisa just shared that there are two different interventions that solid ground wellness and recovery use, for instance. And I, as a researcher, might think, oh, is the intervention efficacious? And is it effective? And these are things that we think about as researchers or as providers, for instance, in the care, in this case of students, to figure out, are the efforts that we're putting forward, are they actually going to make a difference? And we can use research to inform our decision making. So efficacy refers to how a treatment or intervention works in a controlled research environment. When you have an intervention in a controlled research environment, what that means is that you have trained the staff to implement the intervention. You watch the staff implement the intervention. You choose criteria of the participants who will receive the intervention. So this is what we mean by a very controlled setting. When we think about efficacy, how does a treatment intervention work in specific populations? So strict inclusion and exclusion criteria. Maybe it's only with students who are in recovery from a specific substance use disorder. Maybe it's students who are in recovery from marijuana use, or students in recovery from cocaine addiction, for instance, or dependence. So very specific characteristics between a particular age group, for instance. And then there's particular kinds of statistical analyses that you would complete with the treatment group. Inherent potency of the treatment. So there's this understanding that there will be a particular impact of the treatment. When we think about effectiveness, so efficacy again in a very controlled environment. When we think about effectiveness, this is in real world settings. So think about acting out our daily lives. It's not in a controlled environment. It's super messy. We don't really know what's going to happen exactly in our environments. Anything can really happen. We have anticipated things that we think are going to happen, but it's the real world. When we think about effectiveness, we have to question, is the treatment known to be efficacious? Okay, then does it work in a real world setting? So if it's efficacious in a controlled setting, when we put it in a real world setting, what happens? Is it still efficacious? So how a treatment works when applied to a population across the board. So in this case, we're not putting all these exclusion or inclusion criteria. It's very much more so representative of our everyday lives. And then you use statistical analyses on all persons. It's focused on the practical application within treatment settings. There's a difference. Controlled, I mean, generally thinking about it, efficacious is really in these very controlled environments versus effectiveness in real-world settings. An example of efficacy versus effectiveness. So for instance, we can say that in a randomized controlled trial, very controlled setting, again, for instance, where the staff members have practice and training and monitoring of treating individuals, for instance, with antidepressants for depression. We can say that maybe the research study in a randomized controlled trial finds that antidepressant medications are shown to be efficacious 85% of the time. But when you take that same approach, same treatment, and place it into a real-world setting in a really busy, federally qualified healthcare center where there's really low resources and providers have very limited capacity, then what happens to this treatment that is proven to be really efficacious? When we think about that, then maybe that antidepressant medication is shown to be effective only 60% of the time. And why might that be? Well, in a real-world setting, you're not controlling for everything, and there's messiness. What is effectiveness? It's about producing a definite, decisive, and desired effect in a real-world setting. To figure out how we can prove things to be effective, we have to think about the following things. So we have to have a clearly defined intervention or treatment. It has to have it known to be efficacious. So for instance, motivational interviewing, cognitive behavioral therapy, known to be efficacious in randomized controlled trials. Then the intervention must have been used in multiple rigorous research studies, which have established an evidence base. So not just one time does it need to be tested, it needs to be tested over and over again. And then also there needs to be implementation of fidelity to the model. So are people really implementing it how it should be? Or are they, for instance, implementing part of it? Or are they using language that maybe would be, instead of, let's say, if we're implementing a screening tool, I'm sure you all have maybe experienced this when you've gone to the primary care provider and they say, oh, you don't drink. Nope, I don't drink. Really, how that should have been implemented, if it were fidelity to the model, it would have been something to the effect of, oh, so have you had any drinks in this time period? Or tell me how many drinks you've had in this time period, rather than a closed-ended question and an assumption of you don't drink. So in that way, it's an example of not fidelity to the model. And then also there needs to be implementation of fidelity to the model. So are people really implementing it how it should be? Or are they, for instance, implementing part of it? Or are they using language that maybe would be, instead of, let's say, if we're implementing a screening tool, I'm sure you all have maybe experienced this when you've gone to the primary care provider and they say, oh, you don't drink. Nope, I don't drink. Really, how that should have been implemented, if it were fidelity to the model, it would have been something to the effect of, oh, so have you had any drinks in this time period? Or tell me how many drinks you've had in this time period, rather than a closed-ended question and an assumption of you don't drink. So in that way, it's an example of not fidelity to the model. And also careful measurement of appropriate outcomes. So making sure that the outcomes, health outcomes, for instance, are very well defined at the very beginning of the research with the intervention. And then also making sure that you have a lot of participants, because there's a lot of noise when it comes to the statistical analyses, because you have to consider all these other environmental factors within the context of where the intervention was implemented. And then you have to use very sophisticated multivariate statistical analyses. So when we might think about this as providers who may not have this kind of expertise, for instance, it might be really daunting to think about the question, for instance, that Lisa posed. Can we figure out if one mode of delivery is more effective than the other? Well, we could anecdotally say maybe one way is better than the other, but there are particular ways that you can actually measure and test that. And then you can say, in this particular context, with this kind of patient population or student population, this seems to be effective. So I know last time we talked a little bit about research, and I'm just going to share a little bit more information to set us up for really trying to understand and bring home this concept of comparative effectiveness trials in the context of research. When we think about what research is, we have multiple different kinds of research. Last talk, we talked about community-based participatory research, which is an approach. So it's an approach to be able to engage diverse stakeholders together and to have different voices come together and ask research questions. But when we ask research questions, we have to use methods to be able to figure out the answer or to move towards some kind of an answer. So there's qualitative research, of which I primarily have expertise, and there's multiple different kinds of methods that you can use for qualitative research. For instance, we, at the very beginning of the work that we've been doing through Voice and Collegiate Recovery, we used qualitative methods of photo voice. So we don't have very many photos up today, but we have a few photos over there that are illustrative of students voicing their experiences to being in recovery on our college campus. When we think about qualitative, it's very much one-on-one interactions, group interviews, and the kinds of data that we get are text or visual images or videos. When we think about quantitative data, we often are thinking about surveys. So for instance, you guys are going to do a post-survey. Well, you're going to do a survey at the very end of this. Closed-ended questions, really short, brief. Not always are quantitative surveys short and brief. But the idea is that the data points that we're getting, they become numbers. And so you can analyze the data using statistical methods. And mixed methods is the idea where you bring both of these different kinds of qualitative and quantitative together, different kinds of data that you can collect, and you analyze them in such a way that maybe the qualitative explicates and explains the quantitative, or maybe vice versa. The quantitative can help explain a potential pattern that you might see with qualitative data. When we think about the kinds of research that we do for comparative effectiveness research, it is very much involving these different kinds of methods, including mixed methods designs, and there are different kinds of designs that can be used. So there can be a pre- and post-test design, which basically that's an example of if I came in here today and I gave you a survey of 10 questions and I asked you things like, what do you know about comparative effectiveness research? What do you know about the different kinds of research? What do you know about evidence-based practices? What are some examples of interventions? And then I asked you the same questions immediately after the presentation. What would we anticipate? That you'd know more, right? That's what we would hope. I mean, I'm hopeful that you guys will know more at the end of this talk than at the beginning of the talk. But that's a pre- and post-test design. And we say in research it's pretty weak. It's really, in this case, it's about a 50-minute presentation, maybe less, or discussion. And that's really not enough time or ways for you to be informed or to obtain information. And maybe it's just really not like we're intervening for momentary, we could say. But, how much difference are you really going to see? And then also thinking about comparison groups. So this is stronger, where you have a control group and then you have another group or two other groups, for example, and you are making comparisons among these groups. And then we have what we consider to be our gold standard, which is randomized controlled trials. And this is where we have a control group and then we have a treatment group. And the treatment group gets the intervention and the control group doesn't get the intervention. Or maybe they get a different kind of intervention. Or maybe you have two arms that are treatment and you use usual care or treatment as usual as the control group. Can anyone think of an example of a randomized controlled trial? Yes.
My name is Dick Jeske, and I'm on the advisory board from the community. I was the coordinator of a women's prison program from 1991 to 1998. And in 1996, UCLA did an outcome study. And if you're interested in it, it was just look up Forever Free Outcome Study UCLA, and there's all kinds of stuff on the internet. I just looked at a 247-page outcome. What they did, they used a randomized controlled trial where they took 196 women who had been through the Forever Free program, and they took 196 women who had not. And they compared recidivism, they compared effectiveness out of the community, they compared how often they relapsed, all of these types of things. And as a result of that, this experimental program that started in 1991, now there is a program in every state prison for both men and women because of the ability to see the difference and to see the outcomes. So that was probably a 50-cent answer for a nickel question, but there it is.
That was a great response. So I just want to reiterate something that you said, that it was really about understanding the difference. So the comparison, where you had 196 women who were in one group with a treatment and 196 women in a non-treatment group. Did I get the number wrong?
The recidivism rate for the control group was 76%. The recidivism rate for the Forever Free people was 34%.
And the Forever Free people were those in the treatment group.
That's correct.
Right. This is a perfect example of a randomized control trial. Yes, I would love another example.
So she asked me if I would do the presentation yesterday, and I said no. But she said, well, I'm going to ask you questions anyways. I'm trying to do my part here. Anyway, so...
Tanya has done work in comparative effectiveness research, trials, although I don't know if it's exactly been called that.
Yeah. So a lot of my work has been in substance use programming in schools. And so I was involved in the Keeping It Real program. And Keeping It Real is a substance use prevention program, so working with people on the front end of the issue in terms of early exposure. Now, Keeping It Real so you've heard of the DARE program? Some of you may have even had it in school. So the DARE program, the current DARE program is basically Keeping It Real, the program with which I worked in. Because the old DARE program, they found it basically encouraged drug use, so that didn't work out too well. So then they had to replace it, and our program, after conducting several randomized control trials, was chosen to replace the DARE program. So basically, it's school-based programming, and so there was a pre-test and a post-test, right? So they surveyed the kids before the teachers implemented the intervention. And then there were several post-tests after the intervention. So there was immediately on the last day of the last lesson, and then they did 6 months and several years later. And then there was a control group, so as well. So there were kids in schools that didn't have that programming; they just had normal classes. And then one of the randomized control trial, one of the trials actually compared versions of the programming. So, for example, one of the interventions was started in 7th grade and followed kids all the way through 8th grade. And so we could compare to 7th graders who got the treatment and 7th graders who did not, following through 8th grade. But then there was another version where kids got it in 5th grade. So they had slight modifications, but basically the same lessons. Because 7th grade, that's certainly when I started using, was 7th grade. And so that's a very common time period of onset. So the thinking was, 7th grade's a good time. But if you've already started, which some kids already have at that point, the idea was you need to start a little bit earlier. So then we had a 5th grade version, and we had 5th graders who got the intervention and 5th graders who didn't, so a control group and a treatment group. Then we had a third treatment option where they got the treatment both in 5th grade and in 7th grade. The idea is you want to plant the seeds and then water the plant, right, in 7th grade kind of thing. So that was a case where we had not just treatment and control groups, but we had several treatment groups that we could compare which one was the most. And I just want to give one other related example. So that was about timing of intervention. So that answered questions about when's the best time to provide this programming. But we also did a series of studies that were associated with cultural specificity in the interventions. So, and this is now going quite back in time now, so what I'm going to say might even seem weird to you because we think differently about these things now. But given the demographics of the United States several decades ago, the diversity was simply to, so we, in other words, you have interventions that would focus on blacks and whites. But it became clear the demographics were shifting, that so we said, okay, we need to create multiple versions. So this intervention, we had the sort of what they called the traditional intervention, which was black-white. And then they compared it to a multicultural version, which was black-white Latino. And then they compared that to a Latino-only version, because this research was happening in Arizona, where the public schools were like 95% Latino. So in that case, that was sort of the culturally targeted. There was the traditional treatment, and then there was also the comparison to, do you just sort of need the colors of the rainbow to reach people? And so we had 3 treatment groups there, plus a control group, people who didn't get any of the intervention, when they got other, you said treatment as usual, which was random other, not random, but miscellaneous other types of substance use programming. Anyway, so yeah, if you want to know what we found that 5th and 7th grade was better than the other 2. Well, just given the population in the schools we were looking at, yeah. So the research position wasn't that Asians are irrelevant or any other group for that matter. There's many others besides those 3. But just that the traditional programming was considered to be multicultural several decades ago if it was just black-white, which, and then demographics really shifted. So, one could argue that even way back when it was black-white, it was still not reaching everybody's needs. And then they also found that the best intervention was the one that was not culturally targeted, but the one where the multicultural, where kids could recognize themselves in it, but not feel like they were being pandered to. Like, oh, this is for me, kind of too much, like you're trying too hard to reach out. Anyway, so that was it. Yeah, so I do want to say one more thing. I just want to say, I love having the microphone, no. But I just want to say one more thing to highlight the distinction between the quantitative research design. So the first bullet is you have a pre-test and a post-test. The second bullet, you also have a pre-test and a post-test, but you strengthen the design by adding a comparison group. And then the third model, you add strength even further by doing randomization. And that is by assigning people to the treatment of the control group randomly. And that way, that takes care of some of the noise that we call it. We call it noise, but basically that means just the general variation, right? So that takes it into account things like gender or race, ethnicity, or family factors or socioeconomic status, right? That those are distributed in the population, and all of those things might relate to various choices that people make, or whether or not they're paying attention in class, or showing up to class for the lessons or whatever. And so that's what randomization does, is that kind of distributes equally in both groups, the treatment group and the control group, all those other factors that might contribute to differences in the response to the treatment. And that's why it's the gold standard. But what you might imagine is that the more you add to it, the more work it is, right? Yeah, and that's where you need more money, and that's why you have to get big grants for that, and that's why community organizations tend to do pre-post designs. And so that's why we have a lovely opportunity here where we can get research, where we've got research. Well, the idea is that we can join together and seek research funding to have the super strong designs, but also work with community organizations who really want that information. Thank you for your time.
Thank you very much. So, Tanya, I actually have a few questions.
Yes, please.
In the randomized controlled trials that you were doing with Keeping It Real, did you initially do trials for efficacy? And then did you do
So by
effectiveness trials?
definition, a randomized control trial is an efficacy trial. But you then, so if the problem is it's harder to do effectiveness trials with randomization. So for example, ideally, the scientific gold standard is that you randomize at the person level because you expect the effects to be at the person level. So we had to make some modifications because there were schools who said, we want to participate in your study, but only if we get the intervention. Otherwise, why else would we want to dedicate our time and resource and not get the intervention, right? And so then because of that, we had to randomize at the school level.
Mm-hmm.
But yeah, typically randomized control trials are efficacy trials.
Mm-hmm. So the idea then is that when you partner with, for instance, in this case, school systems, we as researchers can't do a controlled or implement the intervention in a controlled setting, because we obviously are partnering with school systems in this case, or for the work that we're doing, we're partnering with perhaps student health services or counseling and psychological services. So it's a partnership in terms of thinking about what might be possible within the institution or the agency.
Yeah, or you might be lucky enough to convince a group to agree to the control conditions, right? Meaning all of those specifications that make it a randomized controlled trial. But this is why when you go to do it again in the real world, you might find differences, right? Because all of a sudden you don't get to make all those specifications.
Mm-hmm.
So yeah.
Okay. I think I also want to reiterate a point that Tanya has brought up about randomized controlled trials. Often there are multiple years, and you might do it longitudinally. You might follow individuals over 6 months, 12 months, 18 months. And all of these times are considered data points where you would be collecting information on whatever your outcome measures might be. And that includes a huge amount of staff and financial resources and capacity to be able to do. And so when, for instance, we think about Lisa's question, like what kind of modality, delivery of an intervention, might be best for a particular group, or in this case, college students, for instance, maybe when we would create the design of a study, we would think, okay, for me with my researcher hat on, all right, so we're going to have treatment as usual. That's in a brick and mortar setting. We'll have that at Solid Ground Wellness. And then we're going to have the delivery of the intervention in a cafe that's off campus. And then we're going to have the delivery of the intervention in the residential areas, in the dorms. And what we want to understand is, I don't know, what might our outcome measure be? Are students more likely to adhere to the treatment plan, depending on the mode of delivery, for instance? And then also, what are some health outcomes that we might want to measure? So I know to ask those kinds of questions because of my academic background, and I also know it's going to cost a lot of money, and we're going to have to invest a lot of time into answering these research questions. Whereas the community partner, for instance, when Lisa asked that question, she might not have the same thought process of, oh my gosh, this is going to be millions of dollars. Or, oh my gosh, where are we going to get this funding from? So with the value of the kind of work that we do is we get to have those diverse perspectives and bring them together so that Lisa can pitch the question of what she's seeing in her clinic, what she's seeing in the needs of, in this case, college-age students who are in recovery from substance use disorders or who maybe want to get on the path of treatment and recovery. She has the actual knowledge and experience. And the same with Sarah. Sarah can come to me and say, this is what I'm seeing in our student population here at CAPS. And I can ask her a whole bunch of questions, and then I can say, this is the design of the study. This is where I think we need to ask to get some money. And I think this it's going to cost us that much. And I don't know much about randomized controlled trials, so I'm going to pull in some other investigators who have that expertise. So these are the kinds of things that we, as a team for our Voice in Collegiate Recovery, we are coming together with all these diverse perspectives so that we can ask these questions and that we can figure out what resources and capacity do we need to move forward questions that are meaningful, in our case, to students. So we are happy that you all are here because we do work, in this case, that's very much driven by students and by students' voices. Just to recap, what is effectiveness research? So an efficacious treatment is something that's tested in a real-world setting using randomized controlled trials with specific outcome measures, just as Dr. Neary shared earlier. After multiple trials, we can say that evidence begins to accumulate for or against effectiveness. So if we repeatedly see that in a real-world setting in randomized controlled trials that the treatment or the intervention is continuously efficacious, then we can begin to say that there's evidence to say that it's effective. When there is a lot of evidence to suggest that it's effective, the treatment becomes an evidence-based practice. So, for instance, what Dr. Neary was referring to earlier, keeping it real, that is considered evidence-based practice. There are many interventions that are used that are not evidence-based practice. And what that means is there's not enough evidence to indicate that it's actually efficacious and effective in real-world settings. So then, what is comparative effectiveness research? It's research that compares two or more treatments or interventions that are known to be effective, so that have an evidence base. And the comparisons include different kinds of measures. So there might be clinical outcomes, it could be acceptability, so does the patient population or the population receiving the intervention, do they like it, do they not like it, is it feasible? So within a clinic that has very few staff with limited resources, is it feasible to implement a particular kind of intervention? And then cost. Is it something that, for instance, within the particular environment where it's being implemented, is it cost effective? Or is it something where there's no way the institution or the organization, the healthcare system can actually afford it? Questions for us? Yes?
In terms of not being able to carry out specifications because a control group might not agree, right?
Mm-hmm.
Are there any guidelines on how to evaluate those specific outcome measures, but you can't get the specific specifications you want? That makes sense.
In what sense, the specifications?
As in not being able to randomize down the person into a school, just not getting the kind of organization you want for those things.
Mm-hmm. So Tanya has an answer for that.
Yeah, so one of the types of the ways that an efficacy trial would dictate conditions would be people you don't want to include in the study. So for example, maybe here at UCR we want to compare two programs for students in recovery, where we might say you can only be in recovery, you can only have one type of addictive disorder, you can't have two, or you can't have a co-occurring disorder in an efficacy trial. But in the real world, what are you going to withhold services from somebody on campus who needs them, right? So that's a case where we would say, okay, we will allow them to participate, and the way that you handle that in an effectiveness trial, so that you don't just ruin everything, is that you collect information on it. So you can say, oh, okay, in our sample. So in other words, maybe you find, remember the comparison of 85% to 60% effectiveness of that antidepressant medication. Well, we may find that an evidence-based strategy, that the research said should have X percentage effectiveness. Maybe in our particular case had a little bit less, but we could say, well, maybe that's because of the particular people we had participating. And I don't mean that we would be blaming them for it not being successful, but just that they have different needs potentially, and so and the intervention may not have met those needs. But often what that can do is suggest ways that modifications need to be made, right? So you can take an intervention, and this is part of what we can learn is not only comparing two interventions, but so which one works better, but also why did one work better, and is there anything we can do about the lack? So can you add a complementary intervention, or can you add additional services that might make up for that kind of stuff? So does that answer your question? Yeah, I mean, that's one of the most common ways is that you can't exclude people, that they might have particular complications, or things that complicate the research question of is it effective. Another thing that's really another specification often has to do with the timing of the intervention. So it should be it's a 6-week program, and sometimes, so let's say maybe it got started in the real world, maybe it got started late, and exam week is happening, so they're going to bump up, and so they're going to do a 5-week intervention, or they do, so just in the real world, then you just have to account for things like that, keep that in mind, that maybe if it was less effective, then maybe that was particularly why. So, but in this type of research, this comparative effectiveness research, you're taking two interventions and really comparing which one worked better. And so you can do that in a couple of different ways. You can take the same intervention and look at the settings in which they're administered, in which case then that makes them different interventions, right? A field-based intervention, or a school-based intervention, or a community-based intervention. Even if the content is the same. Or you could compare two types of interventions that are actually different. You could take, recovery meetings and compare that to some other kind of like some other kind of,
Like one-on-one counseling.
you know.
Mm-hmm.
So that's, I think, part of the goal is to peers to find out, you know, at the end of this project is to find out what are the needs on campus, what are the interventions that might meet those needs, and then maybe we can compare them to figure out if, you know,
Mm-hmm.
which one would be more.
So I think an example, bringing it back to Lisa, is, for instance, if she wanted to compare the mode of delivery using a comparative effectiveness research trial. Let's say the intervention itself is motivational interviewing, and it's for individuals who maybe maybe they've had some challenges and struggles, and it looks like maybe they really could benefit from counseling, but they're not yet ready to get into counseling. And so motivational interviewing is a perfect way to really find out, what does the student value? What does the student want to work on? How can we really identify the student's needs? And so using motivational interviewing as the intervention, but then implementing it in different settings. So maybe it's going to be in the cafe, maybe it's going to be at Solid Ground Wellness and Recovery, and maybe it's going to be like in the lobby in the dorm room or something, not the dorm room, but you know, in the dorm area. And figuring out what seems to be most effective. What has the best impact of engaging the student in initial treatment? That could be our question. And so we'd be really looking at the different ways that we could deliver this particular kind of intervention. I think it'd be a great study, Lisa.
We're looking forward to it.
Okay. So that would require us to do a lot of legwork to figure out how could we partner with student affairs in particular and other partners on campus and the community. And so that again brings us back to this idea of community-based participatory research. How can we leverage the different voices on our team to be able to build our capacity to answer these research questions? Because if Lisa were just to say, Anne, I want to do this research, and we just decided we're going to do this research, we get funding, but we've got no buy-in and no support from key campus stakeholders, then we just show up and start doing this research, and I don't think that the school would be very happy. So it's all about negotiation and partnership building and figuring out, is this meaningful not only for the students, but also for the campus and those who are in leadership positions. So this constant negotiation in many ways. So you can see that asking these kinds of questions, the question might be kind of easy to ask, but then actually implementing it becomes sometimes quite complex. And then obviously with the research component to it, there's all these other different things that we need to do in terms of making sure that we're measuring the right outcomes and that we are analyzing the data correctly. And then, of course, disseminating the data. Any other additional questions? Yes.
I was going to say, I have two children, a 39-year-old and a 17-year-old. So the one right now is a senior at Poly and was on varsity sports since he was a freshman. So his peer group extended all the way to seniors and senior siblings who are older in college settings.
Mm-hmm.
So the influences that come to different people who would be in these studies, there's so many variables. I mean, and just developing the right questions, the setting you're saying, the language you use, and not only that, but who are they more likely to be honest with? You know, how do you get that type of thing? So in my experience with that, and also I'm from Detroit, and I've been in a federally funded rehabilitation center, and I've been in one that is like a country club. And you get different outcomes because of the types of programs. And so the question is it's going to take a long time and figuring out who to target and who is going to participate in that. How do you go about deciding, because for myself, peer-to-peer, I know somebody else had lived experience and could relate and empathize, and I knew wasn't being judgmental or you know, behind that face was going, oh, well, you know, no. I was a victim of a violent crime. My teeth aren't this way because I was whatever. So I encounter it all the time. So it's just, you know, digging in and then finding who to, because there's so many variables.
Mm-hmm. So I know Tanya has a response to that.
Yeah, so you raised a lot of really good points. I mean, the good news is there's actually a ton of research on substance use, and we actually have quite a few interventions that have already gone through the efficacy portion of the research, which takes years, and that have also gone through the effectiveness portion, right? So in the course of just developing the interventions, they had to answer those questions. What's the questions meaning, what's the best way to ask this? What's the best, who should we include, who should we not include? So actually we have a lot of information. For example, there are studies that where the research question is just, are people honest when you ask them about their substance use? And then of course, it matters, what are you asking, 4th graders? Are you asking, 19-year-olds? Are you asking 40-year-olds? Are you asking them at work? Are you asking them at school? Who's asking? A teacher? A parent? Etc. So we have answers about all that. And the good news just in general about getting substance use reporting, people are actually very forthcoming. And there are certainly ways not to ask it,
Right.
but generally the research doesn't employ those methods anymore. Of course, now we know. But I think getting to where you're saying, how do we funnel down? How do we decide all these things? I think for me, one way to think about it is, and part of our project is to have discussions with the community about, well, what are the issues? You identify the problems, right? What are the things on this campus that students in recovery need? So those are the problems to be solved. Then what you do, you can put them in a priority order and that kind of thing, but then what you do is you go back to the research and you say, well, what are the interventions that try to address those problems? And what research has been done, right? Because if we're going to do comparative effectiveness research, we want to pick stuff that's been studied a little bit. So then what we can do is we can, prioritize the problems and then prioritize the interventions. Which ones? And so Anne and I, as academics, we're not going to pick that. We're going to ask the community to tell us that. And we come in on the research side and say, okay, we'll help you gather the data and answer the questions and answer the research questions and analyze the data. So that's what I would say. It's first getting the community to identify the problems to be solved, right? So the gaps in services. Think about a priority list, and then go back to the research, which is where we can come in and say, okay, here's what the interventions, the research that's been studied about interventions that address those problems, and then we all say, well, which ones do we want to prioritize to try out here? Again, the scholars can help set up a design that's appropriate by asking appropriate questions and those kinds of things. The community can also weigh in on that as well, because even right now we have so many choices of questions, right? So the community can also say, okay, well, there's this set of questions and this set of questions. Tell us which ones you think would be best for this population, right? So the community can inform those decisions as well. Anyway, did I answer the question? I feel like I'm now anyway.
So I do want to be mindful of time. We are at 6:30. If you have any questions or thoughts about what our campus needs are in terms of students who are in recovery, certainly contact me. Send me an email. Give me a call. I don't really answer my office phone, but my business card has my cell phone on it. Be in contact with us, because we want to ask questions that are meaningful to our campus community, and not just to the students on our campus community, that might also be meaningful to other students who are on campus environments similar to ours. So thank you for coming. We have one more talk, which is November 4th, and that specifically will talk about working with vulnerable student populations, working with vulnerable populations and the ethics and moralities involved in working with vulnerable populations with a focus on students. Okay, thank you for coming here tonight. Thank you. There's a post survey, or a survey. It's not pre-post. Please fill out the survey, and also please make sure to check in and or sign in and give us your email. Thank you.